We continue to refine how we do things and developing additional programs, different programs for different population. And I think of the self-directed funding patient managed care program, and it's putting the patient and the family in the driver's seat. I can tell you we've been at this program, patient managed care or self-directed funding, and essentially putting the patient in the driver's seat. Very, very concrete example. I have a wife that cares for her husband, quadriplegic, very complex services, and came to my office on several occasions and said, I have a solution for you. And it was the patient managed care, which is in the 10-point plan to actually put that patient in the driver's seat. I saw her not too long ago after she was on our pilot project on self-directed funding, or patient managed care as we call it. It was night and day. It changed their lives. She says, now I can do the things I want, but I actually employ those personal support workers, and I let the things that I don't like so much. But you know what? Caring for him at 11 o'clock at night when he wants to go to bed, I don't need a personal support worker that shows up a bit later and so on. I'll do that, but I need help during the day because I work. So that's a solution, that's a program, and I think we need to innovate and continue putting that patient first and putting patients in the driver's seat.
Deputy, I want to go back to your initial comments that the opening of the session. And you talked somewhat about the patient first discussion paper that we embarked on since this winter and the consultations that the ministry has had out there. And one of the comments you made is that based on the outcome of those discussions, as we transform, I guess, or go a different, a different approach, that that would address some or a good number of the others, recommendations. Can you share some insight, how you came up with this statement, I guess?
So to be clear, the changes that we're expecting in that we look at in the discussion document are one element, we think, of improving integration of services in home and community, one element only. And as we heard from Professor Donner, the most important thing is not structural change, it's functional change within the delivery of home care services. I think my colleagues would agree. Issues related to some of the things we're talking about here, self-directed care, levels of care, standardized contracts, bundled care post-discharge from hospital, introduction of technology to care, special focus on the 20% of patients who have palliative care needs within the home care population. These sorts of things are the real fundamental changes to home care practice that probably have been going on. Those kinds of fundamental changes have been going on in hospital acute care for the last 10 to 15 years. I think it's fair to say that home care is now starting to undergo those same strong functional changes that were introduced to hospitals when laparoscopic procedures were introduced that allowed people to be treated as outpatients, for example. Those kind of measurements of outcomes, those kinds of introductions of new technology are coming to home care today.